final physical exam on my mother here. So first, with general survey, we're going to be assessing when the patient first comes in and we're talking to them initially. So we're going to be looking at the stature, her posture, and then also her motor activity when she was walking into the exam room. Also her dress, her grooming, her hygiene, and then her speech as well, mood and manner. Next, we're going to be inspecting the integumentary system. So generally throughout this whole head to toe exam, we're going to be assessing her skin. We're going to look at her color, any hyperpigmentation, moisture, temperature, turgor, edema, integrated lesions, or vascularizations. So next we're going to go on to the head. We're going to inspect and palpate the head for any deformities, also palpate, and then we're also looking at our hair distribution and the fineness of her hair. And then just also inspect for any rashes, lesions, or infestations. Next, we're going to be going to the face. So we're going to be testing cranial nerve 7, which is the facial nerve. So how do you just smile with your teeth, puff your cheeks, frown, raise your eyebrows, and squint your eyes really tight. So cranial nerve 7 is intact. Next, we're going to be testing cranial nerve 5, which is the jaw movements. So I'll have you open and close your jaw. Also, I'm going to be palpating for any dislocations or any crevitus, and her jaw moves fine. And then also I'm going to be testing sensory. So I'll have you close your eyes and you tell me if you feel on your right, left, or both sides of your face.
Left, right, right, both.
Nice. And then I also palpated the temporal and masseter muscles for strength. And I did assess the temporal mandibular joint for edema or edema, and I also palpated it with further range of motion if there was any snapping or clicking. Next, with her eyes, this is cranial nerve 2. We're going to be looking at her eyesight. So we would use the Snellen chart 14 feet away, and I'll have her cover one eye, read from left to right, covering the other eye, and read from left to right, and to assess her vision acuity. Next, we're going to be inspecting the external eye structures. So we're looking at her eyebrows, her lids, her lashes, for any, and her lacrimal structures for any deformities, for symmetry, lesions, debris, or edema. It's very symmetrical. And I'm going to palpate the lacrimal structures as indicated. I'm going to be palpating around her lacrimal ducts here. Any pain at all?
Mm.
Okay. Then I'm going to be inspecting her globe, her sclera, and then her conjunctiva, so her bulbar and her palpebral. So I'm going to have you so the conjunctiva is good. It is good. Also, looking for edema, injection, discharge, or nostrils, and I don't notice any abnormalities. Then I'm going to be assessing cranial nerves 3, 4, and 6, so the extraocular eye movements. So I'm just going to have you follow my finger with just your eyes. With just your eyes. Thank you. And then I'm also going to be assessing for Perla. So I'm going to be using my ophthalmoscope here, or otoscope. Have you just look straight? And then I will do direct too. So direct, look straight. Okay. I'm also going to be looking at her lacrimal ducts. Light does reflect from her lacrimal ducts. And then I'm also going to be assessing for light reflects from the corneal, and then we are going to be assessing for accommodation. So just follow my finger. Oh. So pupils are equally reactive to light and accommodation. Next, I'm going to be looking at her eyes, looking into her eyes with an ophthalmoscope. I would inspect the optic disc for color, sharpness, and papilledema. I do not have an ophthalmoscope, but I'll pretend. So I would look here, and I would see the red reflex, and I would go in more, and then I would look at her optic disc and look for papilledema. Next, I'm going to be inspecting the external structures of her ears for alignment, for symmetry, any deformities, lesions, or skin tags, and also I'm going to palpate the structures, the preauricular, the tragus, the subtonsillar, post-auricular, for tenderness.
Right.
Okay, and then I'm also going to be inspecting the tympanic membrane, or also looking and being observant and assessing pain of ear canal, so to be more careful throughout the exam. So I'm going to be looking into her ear. So have you just turn that way? We am going to be pulling on your ear.
Okay, tympanic membrane is, let's see, I see the cone of light and it's at 5 and it's gray.
No abnormalities noted. Then I'm going to be assessing the auditory, so cranial nerve 8. So via the whisper test. Okey-dokey. So I'll cover one ear, and then you tell me what you hear.
Apple.
Okay. Thank you. Next is the Weber Newton test. As indicated. So tell me if you hear on both sides. Good. And the reading test, air conduction should be greater than bone conduction. So tell me when you stop hearing it.
No.
You hear it?
I can hear.
Nice. And now the nose, I'm going to palpate the frontal and maxillary sinuses for erythema, swelling, tenderness. So I'll press. Any pain there?
No.
Oh. Nice. And then I would transilluminate as needed. Now I'm going to inspect the external nerves for asymmetry, lesions, or deformities, which I do not see. Assess for patency. She's been breathing fine. Probably for stability, tenderness, or masses as indicated. Now, using the otoscope, with my speculum, I'm going to inspect the mirrors, looking for the membranes for color, moisture, edema, exudate, bleeding, ulcers, polyps, septum deviation, or perforation. So, again, I'm just going to have you tilt up.
Okay.
Thank you. Then for the throat, I'm inspecting the lips external. Everything looks normal. I'm going to inspect her oral, vocal mucosa, moisture, gums, loose, missing teeth caries, dental repairs, or tooth pain. So I'll be also open your mouth. I don't know any abnormalities either. I'm also going to be assessing the tongue movement. So this is hypoglossal, which is crayon number 12. So have you stick your tongue out and say ah, and then side to side. So it's intact. And then I'll have, you lift up your tongue to open your mouth, looking at Orton's and Stenson's ducts. And then assessing the hard and soft palate. And then I also saw the uvula, its midline, and then also I tested cranial nerve 9 and 10 with saying ah. And nothing abnormal noted inside the mouth. Next, I'm going to be looking at her neck for tracheal deviation, thyroid enlargement, or carotid pulsation, which I don't see on inspection. Then I'm going to palpate this paracervical lymph nodes. Show it to me. So the occipital, postauricular, preauricular, and then submandibular, subtonsillar, and then submental, and then the posterior cervical chain behind her neck. Anterior, we're going to do one at a time. Okie dokie, and then everything is not out of the ordinary. Next, I'm going to stand behind her and I'm going to assess her thyroid. So I'll have you turn to your right. I'm going to displace the thyroid on this side.
Second.
And then can you swallow for me?
Second.
Okay. And then this way, she's saying it hurts. Displace.
Hurts.
And then swallow. Okay. So, the upper mouth is there. And then I'm going to be helping with her cervical spine for symmetry, any masses, edema, or tumors, general feel, and range of motion. So have you look up and down, side to side, ear to shoulder, and then testing cranial nerve 11, which is spinal accessory. I'll do a band shrug or resistance. Cranial nerve 11 is intact. Next, for upper extremities, we're going to assess shoulder to fingertips for size, symmetry, deformities, tremors, tics, or fasciculations, which I do not note. I'm going to assess her fingernails for color, condition, lesion shape, if there's any clubbing, which I don't see. I'm also assessing her capillary wrinkle here, and her pulses. And we're going to be doing this bilaterally. I'm also going to assess fingers for nodules, tenderness, inflammation, and range of motion. So we're just going to do one side for the sake of the exam, so I'll just have you open and close. And keep open. Try to keep them open. Okay. Any pain here? Okie dokie. And then also grip strength. So again, we would be testing this bilaterally, but I'll have you squeeze my fingers. Okay. Push or pull. Pull. Push. Okay. And then also we're going to be inspecting the wrist. So we're going to do rotation. So rotate your wrist. Flexion. So here, go up. Extension down. Supination. Pronation. Okay. And nothing noted abnormal. Next, we're going to be inspecting popping the elbow. So we're going to be assessing elbow strength after each spine stable. So we're going to have you arm up straight, flex, extend, and then to straight. Try to fold. Fold your arm up. That's it. Okay. Same thing here. Okay. Next, inspecting and palpating the shoulder. So flexion, extension, or flexion, extension, adduction, internal, external rotation. So I'll have you put your arm out like this, flexion, and then extension, bring it back, and then abduction off the side, adduction back up, internal rotation,
Just one arm?
Yeah, and then external. There you go. So both arms seem good. Also palpating her shoulders here. And up. Yes. Okay. And then we're also going to be observing body position during movement and rest, examine muscle mass of upper extremities, and palpate for epitrochlear lymph nodes. And then we're going to be doing the posterior thorax. So I would inspect and palpate the spine for tenderness, curvature here. Look at the AP to transverse angle, which would be 2:1. And then assess respiratory effort, anterior posterior expansion, and tactile and vocal firmness if indicated first. And then I'm going to palpate the chest, maybe percuss the chest, and I'll be doing in a lazy S motion. And it should generally be tympanic in sound, not dull, because that would indicate consolidation. And then I'm going to be auscultating ones for breath sounds. So every time you feel the stethoscope, just take a deep breath in and out. And then can you raise your arm up, your right arm? And then take a deep breath in and out. Okay, and that's the right middle lobe. And then I will be doing the same thing to the anterior thorax, the same thing, inspecting respiratory effort, inspecting the shape, palpating for any tenderness as indicated. Collarbones. And then percussive chest for resonance as indicated. So again, we want to hear timpani. Okay, and then again, when you feel the stethoscope, just take a deep breath in and out. And then again in the right middle lobe. Then we're going to be inspecting for jugular vein distension. So I'll have you just sit back and then just relax your. If you're looking for JVD, which I don't see. And then we're going to be auscultating the carotid arteries. And we're using the bell. And then I'm going to be palpating if there is no bruise you did not hear. Okay. Then supine. So I'll have you, or if the patient was laying down, I would inspect the point of maximum impulse with a tangential lighting, and then palpate the apical impulse for size using 3 finger pads. Then I'm going to inspect her precordium for heaves and lifts, and then palpate the precordium for throws.
These down.
And then I'm going to be auscultating her heart sounds. Also, when palpating, yes, I palpated the radial pulses already, and then capillary inflow bilaterally. Now I'm going to listen to the heart sounds. And then S1 should be heard greater in the mitral and tricuspid, and then S2 should be heard greater in the atrial and pulmonic. Abnormalities heard. And then with the bell, I would auscultate. And then I'll do the abdominal exam. So I'll have you lay down now. Thank you.
I'm gonna fall asleep.
So at first I would be inspecting for scars, tissue, striae, rashes, lesions, any abnormalities, peristalsis, or any aortic pulsations that I see in bulges. Also inspecting the contour. And then I'm going to auscultate for vowel sounds first. Using and then I would also auscultate the aorta, renal, and iliac arteries for bruise with the bell and diaphragm. But I'm going to be doing the bell for this exam. Then I'm going to percuss tympani over the abdomen. So it should be generally tympanic in sound. And then I'm going to be percussing the liver span. So I'm going to work my way down, up, and then up, down, and I will assess the liver. So where it's dull, and then I will work my way down, and then wherever it's dull, I measure inches, centimeters in span. Then I'm going to be percussing the spleen first, then my belly. And then I would assess if it is going past the LT costal margin. Then I'm going to palpate lightly for tenderness, guarding, and superficial masses. Okay, so I'm going to palpate your abdomen now.
Mm-hmm.
Any pain?
No.
Okay. So pain on light palpation. Then we're going to be doing deep palpation. So this is my dominant hand. Sit down. I'm going to palpate deeply, okay? Mom,
Mm-hmm.
I'm going to palpate deeply.
Okay. Mm.
Sorry. palpate the liver edge for enlargement, tenderness, or irregularities. So, sorry.
Oh.
Okay. Then I'm going to be doing Murphy's sign, which is the hooking technique. So I'm going to go here. Take a deep breath in and out. And should palpate the liver. Here, sorry, I'm blocking hooking technique. And then Birdie sign. So we're palpating deeply. Do you feel pain here at all?
Mm-hmm.
Okay. And then rebound tenderness. Do you feel any pain? Do you feel any pain when I release?
No, you're pressing.
Okay. And then obturator and psoas sign, which indicates peritonitis and appendicitis. So obturator would be moving the. You feel any pain? Okay. And do you feel any pain? No. So no indication of appendicitis or peritonitis. And then we would have her sit up to observe any hernias, and then palpate the inguinal nodes bilaterally. Sorry. And then palpate the femoral post for amplitude and symmetry. Now I'm going to inspect her hip joints and palpate them, and do this bilaterally. Individually first, and then you compare them bilaterally, and then palpate with range of motion of hip flexion, extension, abduction, adduction, internal and external rotation. So I'm going to have you flex your hip up, and then down, extend, and then abduction, adduction. So I'm going to have you move your leg outward, and then back inward. Thank you. And then I'll have you just turn to your side with me.
Which side?
To your left side. And I just want you to bring your leg out this way, or rotate in or out. So those are all good, and then I palpated them. I also assessed the hip strength, and after I found both hips stable, and then it's both strong. Now I'm going to have you sit up. So I'm going to inspect and palpate the knees for any abnormalities which I do not see. Now I'm going to assess the knee strength or range of motion of the knee. So I'll have you flex your knee up and then down, extend. Good, and then after I would assess the knee strength after found stable. And then, I'm going to have you lay down again. Facing up? Yes.
Can I close my eyes?
Yeah. And I'm going to assess anterior and posterior drawer test. So I'm sitting on her foot here, assessing the ACL and PCL.
Ticklish.
Oh, sorry. I'm finishing. Okay. So I don't note any lag or pull of her ligaments, so that's good. And then McMurray and Lackman's is testing the ligaments here too.
Ticklish.
So I'll just have you, I'm gonna angle your leg like this, leg outward, and I'm gonna go in. Does it hurt at all? Okay. And then also do this. Does it hurt at all? Okay. Sorry. And then inspect and palpate the ankles. You can see here. So we're going to be doing ankle dorsiflexion, so like a gas pedal. And then, dorsiflexion is up, and the plantar flexion gas pedal. And then I'm going to have you everversion. So ankle your foot like this, or everversion, ankle your foot outside like this. So like this. And then use your ankle to move your foot this way. Okay. And then rotation, I'll have you rotate your ankle like this. Rotate your ankle like this. Good. And then after assessing that, I would test your ankle strength. And then also palpate the toes. So open your toes like this. Open your toes like this. Open. And close.
Stop, so
I know, yeah, it's okay. And then also assessing for deformities, tenderness, edema, and then also palpating the distal pulse. Bilaterally, I would too as well. And then we did the plantar flexion. We did the plantar flexion as well. And then now I'm going to have you sit up. Mom, we're almost done.
I'm falling asleep. Sorry.
It's okay.
Where's your brother? Okay.
Okay. So now we're going to be testing the coordination, so cerebellar function. So I'll have you do heel to shin again. So with
You
your
can see it.
heel to shin. So I'll have
Heel to shin. Sorry.
I would have her do that. Sorry, we just did the neuro exam not too long ago. And then also superficial pain. Or superficial pain sensation of distal great and small toes. So if you close your eyes, you tell me where you feel the pain.
Big toe, top, pinky,
Okay. How about now?
right, small toe, big toe, right.
And then I would also do this on her thumb, her middle, and her pinky finger. Where do you feel it?
Pinky, thumb, middle finger.
And then you're gonna tell me if you feel sharp or dull.
Okay. Dull, dull, sharp, dull, sharp, dull, sharp.
Okay. Thank you. And then also we're estimating capillary refill time, which should be less than 3 seconds. Examine the nail color as well. And then we're going to be assessing her DTRs, her deep tendon reflexes. So we're going to be doing her patellar and her Achilles. Just relax though. Sit a little more back. Or like scoot your bottom more so your feet are hanging. Okay. And then Achilles. Just relax. And then I would also be assessing for the Babinski reflex. So her toes shouldn't curl outward. As an adult, it should be only curling inward. Okay. And then again for other cerebellar cerebellar function of the proprioception, we're going to do point movements. So we sit up a little bit. So with your pointer finger, you're going to touch my finger to your nose. And then we're going to do rapid hand movements. So patty cake, so go like this, as fast as you can. Okay. Thank you. And then stereognosis, so I'll have you close your eyes. Any total object I put in your hand.
Tooth pick.
Okay, thank you. And in rhapesthesia, I'm going to draw a letter on your hand. You tell me what letter I wrote.
Z.
Yes. Okay. Superficial pain assessment, I had done that previously. I did a sharp and dull, and then deep tendon reflex of the brachioradialis, the biceps, and the triceps. And I redid the bilateral deep tendon reflexes. So we're going to do just rest your arm for brachioradialis. Okay. Her bicep. Again, just relax your arm. I did see. Oh, you can't even see. I'll do the brachioradius again. That's okay. Relax your arm. I don't see because I. Her bicep. It's hard because I'm left-handed. Okay, and then her. Okay. Thank you. And then we're going to be conducting Romberg's test. And then, as well as pronator drift. So I'll have you stand up. Romberg test. I'm going to have you put your feet together. Feet together. A little bit as together as you can. And then close your eyes. And then she would ideally stay over 20-30 seconds. We're going to see if she falls. If you feel like you're going to fall, just open your eyes. So let's say 20 seconds have passed and she has passed the Romberg test. So now since we have assessed the Romberg test, we're going to be assessing her gait. So we're going to do tandem walking first. So I'll have you start over here. So while that was happening, I also assessed her normal gait. So I'll have you do heel to toe. So heel to toe. Okay, thank you. And then we're ready to do walking on your heels. And then coming back, you're gonna walk on your toes. Okay, thank you. And then we're gonna also have her do flexion, extension, and rotation of the spine here. So I will have you just flex a bench at the waist. So I'm also assessing the spine and our hip joints too. Also palpating, no abnormalities, no signs of scoliosis. And then I'll have you extend back, hyperextension there, thank you. And then I'll have you go like this. And side to side, there. And that concludes the end of my final physical exam. Thank you.